Welcome to Module 4 in the NPSF Certified Professional in Patient Safety Review course. Each module in this series addresses one of the 6 patient safety domains that are included on the CPPS exam. This module will address risk identification and analysis. This material was adapted from a presentation given at the 16th Annual NPSF Patient Safety Congress. The presentation was given by Erin Graydon Baker, Director of Risk Management and Patient Safety, Maine Medical Center, Karen Fresh, Chief Patient Safety Officer, Duke University Health System, and Karen Garvey, Vice President, Quality, Safety, and Performance Improvement, Parkland Hospital and Health System. The content outline for the risk identification and analysis domain is A. Implement a systematic approach to respond to data sources such as safety alerts, product recalls, and industry alerts. B. Develop a mechanism to report identified risks. C. Perform activities to identify gaps and risks. D. Review events and near-miss reports. E. Perform root cause analysis, or RCA. And F. Share findings and action items from safety investigations with frontline staff members and other departments. The items in the content outline are addressed in 5 objectives. 1. Discuss approaches and mechanisms for reporting safety concerns and risks. 2. List key attributes of an electronic reporting system. 3. Discuss the importance of including a focus on reporting near misses through any mechanism used to report safety concerns. 4. Describe patient safety organizations, or PSOs, and the importance of aggregate data analysis. 5. Discuss the importance of RCAs and proactive FMEA in the institution's strategy to identify and mitigate risk. First, let's talk about reporting patient safety concerns and risks. The importance of reporting was discussed in detail in Module 1, which addressed culture. We certainly want to be sure we capture the concerns of staff and employees at our institutions because that gives us a full qualitative view of patient safety. We know that safety reports can provide the internal data that's important for us to know. It's vital that we support psychological safety. This means providing an environment that allows people to speak up and not feel there might be a punitive response. There also needs to be a way to provide feedback and recognition of reporting. So on a busy clinical day, we want to acknowledge and thank people for reporting. One way to do this is by sending out good catch letters that thank staff for reporting. Acknowledging people for taking the time to report is a good practice. It's also important to make use of the information. This means taking the time to analyze information and recognize trends. You want to look for trends over time and, if you work in a multi-facility organization, from one facility to another. If you work in a health system and you look across hospitals or facilities, try to identify common defects. Take the information and learn to share with others, whether that be at a safety team meeting, at a briefing, or in periodic huddles. Then maybe provide a quarterly summary of solutions. The summary of solutions is a way to support the value of reporting by acknowledging the people who do the work. There are several methods for collecting safety concerns. First, we will talk about voluntary reporting systems, then we will address learning boards, patient safety leadership rounds, and systems to collect concerns and complaints from patients. What are the key attributes of a good electronic event reporting system? It has to be quick and easy for frontline staff to report. The ability to easily report a concern is so critical. The system should allow the user to save a report so if the person is interrupted, they can come back to it later instead of starting all over. The system should send alerts to the appropriate people who need to take action. It should also use a standard taxonomy. The Agency for Healthcare Research and Quality, or AHRQ, has some common formats that make this easier. Another good attribute is the use of free text for storytelling. Capturing drop-down data is valuable, but the qualitative reporting that you get from free text and from the details is vital. Making it easy for managers to follow up is also important. The use of sophisticated report writing is also valuable. You want to have the ability to pull reports from the system. Take a minute to reflect on safety event reporting and near-miss reporting at your institution. What % of reports are near misses? The answer will differ for each organization, and it provides an opportunity to learn about things we can fix so we can avoid harm. This is a really important part of near-miss reporting. It helps us identify latent failures as well as active failures and plug up some holes in the Swiss cheese. It's a way for us to strengthen our defense mechanisms within our institution and prevent future harm. If a patient or family member hears about patient safety work and knows you put a big focus on learning from past events to be able to prevent future events, this is an important part of the work. Think of the power when you can aggregate the information under the protection of patient safety organizations, or PSOs. PSOs are designed to improve patient safety through analyzing a number of reports, not just at your hospital, but at other organizations within that PSO. The key to this is sharing lessons learned, making sure we don't learn the hard way at multiple places. PSOs are independent external experts because they collect information from a number of facilities, which can then be analyzed and aggregated to help us understand common concerns about patient safety on a local, regional, and national basis and to help us improve. Learning boards are a strategy that some organizations use. They provide a space for frontline workers, staff employees, and physicians to share concerns or defects that are visible to the frontline. They promote transparency and require psychological safety so individuals have the courage to make visible a concern about patient safety. The nice thing about these boards is that, in addition to showing transparency and sharing the concerns, they also show a visual display of resolving the concerns. Again, they provide a way to show the value of reporting by acknowledging the people who take the time to do it. With a learning board, when someone has a report or concern, it's put up in red. As the problem is worked on and people begin to think of solutions, we move to yellow. When each issue is resolved, it's moved over to the green part of the board. One nice thing about learning boards, we all look for data to help us understand how we're doing in our culture and closing holes in the Swiss cheese. The boards can use quantitative metrics. For example, how many defects were resolved in 30 days, how many were resolved by frontline providers, and how many required input of leaders in the organization. Metrics help us describe ongoing work on a daily basis. Learning boards can also be used in the setting of walk-rounds. Your institution may call these patient safety leadership walk-rounds, executive patient safety rounds, or something else. Walk-rounds were first developed by Dr. Alan Frankel, and they serve multiple purposes. One is to solicit information from frontline providers about concerns related to patient safety. This is a way to change the culture and develop transparency. It's an opportunity for senior leadership to model that patient safety is a priority. It's so important that senior leaders take the time to walk around and ask about concerns from individual units. Patient safety is all about how we do what we do on a unit level where care delivery plays out. When leadership can openly discuss failures, it has a real impact on culture. So it's a good idea to encourage frank and open discussions. You can use quantitative metrics to aggregate the information and make sure you allocate the appropriate resources to address some of the concerns that are raised that can't be addressed at that local level. Implementing walk-rounds is not simple. It takes preparation of hospital executives who are not going to do this as just one more thing to do. There needs to be a real intent to model the message that it is very important to have conversations about patient safety. Unit participants also need to be prepared so they know when people will be coming around and who will be coming around. They need to know that the frontline and managerial staff opinions about patient safety issues are important and need to be shared. The process can be facilitated by providing sample questions in advance. Make sure that introductions are made so that frontline staff really knows who is there on the rounds. Certainly, guests can be invited. You may include board members or patients and families. Concerns have been elicited from patients and families while doing rounds to make sure we get the full perspective on the risk that exists in the unit setting. During safety rounds, include a scribe to capture the concerns and enter them into a database so you have metrics that show what % of the concerns raised have been addressed. Timelines are a great way to provide feedback. Providing feedback to an individual who raises a concern, especially if it makes a difference in an outcome or if it is shared with another unit, is so critical. It's such a good way to celebrate the input of every team member. It's a great tool to help develop your culture. You may want to provide sample questions for individuals who are beginning walk-rounds. Suggest they use open-ended questions such as, "Can you give me examples of patients we've harmed?" It is a powerful message to a frontline provider for that language to come directly from a leader. Other good questions are, "What's the next thing that will harm someone?" Or, "What happened during your shift today?" Get to a personal level about where risk lies. There can be more specific questions as well. With a scribe and a database, problems that have been raised during past rounds can be readdressed, and you can review how they were resolved. Issues raised through voluntary reporting systems can be addressed in walk-rounds, so there is a lot of opportunity for enhancing a discussion about patient safety and what is being done to improve safety and mitigate risk. So we've looked at a lot of patient safety practices, and executive patient safety rounds do have data behind them to suggest they are effective. In one study, individual clinical units that had more than 60% of their caregivers reporting exposure to at least one walk-round had a significantly higher safety climate, greater patient safety risk reduction, and better feedback on actions taken. Repeated exposure to walk-rounds is a way to build culture, and we have some beginning evidence supporting this. Finally, when collecting safety information, we certainly encourage eliciting concerns from patients and families. There are vendors out there with systems that allow direct reporting by patients and families. We can also talk to patients and families during walk-rounds. Another method of gathering input from patients and families is through the development of patient advisory and advocacy councils. So reporting systems, learning boards, and walk-rounds can help provide a retrospective or real-time view of risk. This is obtained when you walk around and ask people, what is the risk here now? It's also important to take a proactive look at risk, and one of the most common strategies for this is failure mode effect analysis, or FMEA. FMEA is a proactive, prospective analysis that is used to prevent problems before they occur. It's something we use to analyze potential failures of systems or processes. The focus is on what could go wrong instead of what did go wrong. To use FMEA, identify a high-risk process that is coming up at your facility. Maybe you're about to open a new cath lab or create a stroke center. With FMEA, we use diagrams to think about the process at a high level and brainstorm potential failures that could be involved. We might brainstorm a number of areas, which we then have to prioritize. Then we can begin to identify the root causes of each failure so we can fix these potential defects before they happen, redesign the process, analyze that again, and test it. By the time we implement the redesigned process, we've taken some of the risk out, identified some of the pitfalls, and removed them before they led to harm. Now, whether we're talking about proactively trying to look for possible failures or retrospectively trying to identify adverse events, it's important to think about why things go wrong. The reasons things go wrong can usually be divided into a few big buckets. One issue is organizational factors. What is the culture in the organization? For instance, do you condone workarounds? Are people encouraged to speak up if something isn't right? Do you have well-constructed procedures or policies to address the work that is being done? You can also look at environmental factors. Do you have the equipment needed for the tasks required? Are there more things to do than people to do them? Is everyone working as efficiently and effectively as they can? Finally, when looking at why things go wrong, you can look at human factors. Is the training provided adequate? Do you encourage people to solve problems as they arise? So there are multiple categories to think about, and many areas where errors occur. Some are system and process related. Unfortunately, in many instances, we blame the person when something goes wrong. So we have to be sure we focus not only on the sharp end, which is the clinical providers involved, but we also need to focus on the systems and processes involved. We need to work hard to not set up a situation where frontline providers find it easier to do the wrong thing. We need to make it easier to do the right thing. Next, we want to talk about root cause analysis, or RCA. This is a process for identifying the causal factors that underlie variation in performance. During an RCA, we really want to determine the fundamental reasons why a failure happened. Why did a situation or performance occur that did not meet expectations? It is a retrospective and reactive analysis rather than real-time and is most often conducted in response to an adverse event. It also can be initiated because of trends in the reporting system. We might tend to begin by saying, "It's not my fault." This reflects the fact that sometimes it seems like we want to find the guilty person right away. But RCA guides us to look at systems so we can improve safety in the organization. Let's summarize the phases of an RCA. Some of you have participated in these at a high level. Once an event occurrence is submitted, a report comes into the safety reporting system. The risk management or patient safety office receives a call. The initiation phase includes making sure the appropriate persons receive prompt notification for anything that needs to be done immediately while you gather information to understand what happened. Next is the screening phase, which includes reviewing events for accuracy or severity. This helps you understand if this is an event for which a root cause analysis is indicated. Serious safety events require root cause analysis. And although it can be done for any event, it is a high resource process. There are other ways to analyze our processes. For example, learning from defects is a simpler tool that doesn't require as many resources. For the RCA, the analysis phase requires scheduling several meetings in order to move through the identification of root causes and to develop the action plan. The monitoring phase is also important. Once an action plan is developed and implemented, you need to monitor that and look for potential changes that might be required based on results and feedback. We have all experienced hindsight bias, having 20/20 vision looking back on an event. This occurs because knowledge of the outcome of a previous event increases the perceived likelihood of the outcome. As you're doing a root cause analysis, recognize and be aware that you may tend to have some of these thoughts. We also want to talk about focusing on what's important. This slide has large text in the background that says, "This sign has sharp edges." In smaller type it says, "Also, the bridge is out ahead." This is a reflection of the fact that there are a lot of things going on and we can get distracted. Conducting a root cause analysis helps us focus on what's important. Guidance is available from the Joint Commission to help you do a thorough and credible root cause analysis. Thorough means you look at a number of areas to understand root cause. This includes human and other factors, as well as analysis of underlying systems and processes. There's a matrix that helps you look at these various areas so you can identify all risk points and discover where there is the potential for improvement. Credible means you need varied members on the team, including people who don't work on the unit where the incident happened. Their eyes are open in a different way, and they can help you see things differently and avoid groupthink. For example, you may have people who work in a maintenance department who come in with a different point of view and different questions. They can speak up because they're not involved in your day-to-day operations. But you do want the RCA to be internally consistent. For example, suppose the CEO rarely shows up at the RCA meetings, and one day a particularly damaging error is being addressed and he decides to attend. So you might have a last-ditch effort to get hold of everybody who is going to be in attendance because he normally never shows up. In such a situation, it's important to let attendees know that the CEO is planning to be at the meeting because if they arrive at the meeting and are surprised by his presence, it can cause distrust and damage relationships. But do you think anybody will speak up about root cause when the CEO is sitting at the table? When we talk about internally consistent, that's exactly what it means. You want people there who are normally there. This will allow people to feel safe in the environment and to talk about what occurred. So internally consistent, yet varied participants is absolutely paramount. Another element of a credible RCA relates to the questions that are asked and the answers that are given. You definitely have more conversation when questions are asked in a thoughtful, open-ended manner, rather than just being questions with yes or no answers. And when it comes to the framework, not applicable and no problem are not acceptable answers and should never be used. The framework requires that a specific rationale is identified. In addition, do you tend to focus on the negative in a root cause analysis? Or do you focus on what was done well? You really need to focus on the positive things because people need to hear it. It should not all be negative. Even though you may be at a meeting to discuss poor outcomes, you still want people to know they still do good things. It's a cascade of events that occurred that caused the bad outcome. So the Joint Commission Matrix helps you identify all risk points to determine where you may need improvement. If you have not used the matrix, it's a great tool for making sure you are looking deeply at all your processes. When you are thinking about a thorough and credible root cause analysis, you want to drill beneath the surface. For example, here is a series of questions that gets to the root cause of why did the nurse not check the alarm? The first answer is the alarm always goes off. So then you ask, why does it always go off? The answer is because there is a range that we set it at in terms of heart rate. The next question is, why don't we set it for each patient? The answer is because the system has no flush function to do that. So by asking these whys, it helps you to see the root cause better than a surface answer. Answering all the matrix elements can help you achieve a thorough and credible root cause analysis. It helps you find out what soil is contaminating that area. It's also important to share the lessons learned. This is especially challenging if you work in a multi-system organization. How do you get these lessons to the areas that are impacted? During the root cause analysis, it's important to address other areas or services that might be impacted. If this is happening in your interventional radiology area, could it also be happening in your endoscopy or main surgery areas or in your labor and delivery suites? These are things to identify and to share and cascade that information across the health system. The major elements of an RCA are a timeline, the framework, the cause and effect Ishikawa diagram of the fishbone, and the process flow documents, of which there are 3. The 3 documents are what happened, what should have happened, and what are you doing to fix it. And if you really think about the maturity of your organization, do the safety people always have to create this? The people who know best about what happened are the people at the local level. In a mature organization, you could ask them to put together the process flow showing what occurred. It may give you more insight into the process. It will also give them more involvement in the process so you will have buy-in. Many of you have read so much about patient falls that you could recite a lot of the literature. So instead, why not ask the frontline staff to pull the articles and bring that information forward? They're the ones who need to know it. Enlisting their help will facilitate buy-in, and it will make a huge difference. The final element of the RCA is the action plan with the measurable action items. There are weak and strong action items identified on the VA patient safety site, and these will be addressed later. You need data to audit. Some organizations have pools of folks to actually do the audits, but many organizations struggle with that. There are more audit tools out there that will allow you to cross-pollinate. If your accreditation folks are out there doing tracer surveys, can they also be auditing some of the things going on in your action plan? It's a good idea to share these things across boundaries. The slide shows an example of a fishbone diagram. The bigger buckets of patient healthcare materials and equipment can be changed to show what a particular case is about. The major spines and the smaller bones show how intricate this item can be when looking at a big issue. Some of the fishbone diagrams used in medication safety that look at things like heparin can be quite large. By enlisting the people locally who have the most expert knowledge, you can obtain some of the information you need. You may be told one thing by management, but it's not the reality of what's going on at the frontline level. Next, let's look at the Joint Commission's expectations for action planning following a root cause analysis. For each finding identified, there needs to be an indicated action, an expected implementation date, and an associated measure of effectiveness. The actions need to have an impact on the organization. Some people have a difficult time writing measures of effectiveness. The quality people are really good at this because they write a lot of the CMS 2567 action plans for the Centers for Medicare and Medicaid Services and all the surveyors. They really know how to write these, so if you need assistance, you may want to enlist their help. In developing action items, make sure the measure will be effective and consider whether pilot testing is needed. The improvements to reduce risk should ultimately be implemented in all areas where applicable. You may identify an immediate area, but how do you expand the goal to get it into those other areas? When you set goals, they should be SMART. This means the goals are specific, measurable, attainable, realistic, and have a time element. We mentioned the hierarchy of actions earlier. The VA National Center for Patient Safety talks about weaker, intermediate, and strong action items. For example, things that educate or rewrite the policy are in the weaker area. To say to someone, just remember the next time around, circumvents the rest of the individuals who could learn from the situation. Examples of intermediate actions include educating people and providing a checklist. The checklist could be a support, but it's not the end-all and be-all. Examples of stronger items include not depending on staff to have to remember to do things. Instead, construct the environment so it actually helps people operate in the manner we want them to. Specific types of weaker actions would be double checks, posters, or a new policy, procedure, or memo. But people are inundated with knowledge anyway, so will they read these things? Other weaker actions are training individually and additional study and analysis. What are some more detailed examples of intermediate actions? Redundancy is one example. The elimination or reduction of distractions does help, but it's not superior. Checklists or tools can help us remember, but they are not a guarantee. It takes the willingness of the person using the aid to make it most effective. Eliminating the lookalikes and soundalikes may help. Readbacks may be useful, but what is the process for the readbacks? Are they effective? Have we truly standardized, or is there variation? Software enhancements and modifications may help, but they certainly create their own risks. Increasing staffing and decreasing workload may not be as effective as one might think. Most of us work better when our workload is higher. We keep our brain engaged, and as long as it's not overtaxed, the brain functions well. When you don't have enough work, this can have a reverse impact on the brain, as it doesn't function as effectively as compared to the environment with more work and stimulation. The brain doesn't function and click as effectively in a busy environment. So adding staff and decreasing workload has a reverse effect. And enhanced documentation and communication can also be effective. Next, let's look at the actions identified as stronger. Facility changes would be in this category. Another stronger action is simplifying the process, really teasing out the continuous improvement perspective and getting the noise out of the equation. Other stronger actions are standardizing equipment or processes to reduce variation, and conducting usability testing before actually purchasing new devices. So what are the important measurement questions? What is to be measured? Why is it measured? What is gained? Who will measure it? How frequently will we use the data? Sometimes we just audit and get data, but we never utilize it. So what's the effectiveness of it? What are the available resources? Follow-up is important. When we engage in a thorough RCA, we learn an awful lot, but we are using resources in terms of people's time, effort, and the work involved. It's important to recognize employee efforts. We really need to listen when they talk about the impact and help share the lessons learned. We can use data to help show impact, but stories are important as well. Monitoring the plan along the way is important to ensure it is executed and that there is follow-through. Mark your calendar for 3 and 6 month follow-ups. Everyone is frustrated when they have to use a lot of energy with repeated sentinel events and conducting RCAs for events that occurred previously. And we really want to keep leadership informed of both progress and barriers as we share lessons across the organization. Let's look at possible pitfalls of RCA. A lack of leadership support is a pitfall. You need this to be able to bring together all the resources needed for a thorough and credible RCA and then to spread those lessons learned. Another pitfall is skipping some of the steps in the chronology of the event and the analysis. Other pitfalls are relying on policies and procedures, failing to explore at-risk behaviors, not identifying the latent failures, and not exploring the human factors. Failure to seek outside knowledge and selecting weak risk strategies are also pitfalls. Failure to link causations to actions is a huge issue. Having a focus that is either too narrow or too broad in scope is a problem as well. And the final pitfall is being unjust on punitive action. So let's look at a case study. A 24-year-old man with lower back pain was brought in for a procedure to address the pain. During the procedure, with the incisions already made, the operating table folded up like a taco and the patient was in that position for 54 minutes. The OR staff tried to flip the circuit breaker to release the table and free the patient, but that didn't work. Eventually, they called the facilities people who had to cut the power. The patient was extricated and the surgery was completed. The patient's outcome was good and the incident was disclosed to the patient. Although there was no harm to the patient, disclosing the incident to the patient was the right thing to do. Let's look at this using the Swiss cheese model and think about some of the factors and categories involved. We want to think about both active failures and latent conditions that might have contributed to this particular event. The root cause team that looked at this case identified several issues that contributed to the incident. As the case was talked through, it was learned that the health system used several different types of OR tables, so there was variation. It was also learned that the OR team knew there had been problems with this table in the past, but none had been catastrophic, so there were no reports. The table had a telescoping function, with the mechanics of the telescope enclosed in a tin foil-like container. During the surgery, the arm was moved in, and it banged on the tin foil container that had the mechanics. At the base of the table, there was a sign that warned people not to place equipment on the table, but some people didn't see it. The environmental services individuals didn't think their bucket was a piece of equipment, and anesthesia put their equipment in this area. The OR also had a lack of proper shelving, which caused people to put things on the table. It was also determined that there was a lack of proper preventative maintenance on the table. Additionally, pressure to turn over the room affected the way people worked. The root cause analysis revealed several factors that contributed to the error. First, there were human factors in terms of a lack of knowledge of the importance of not placing equipment on the table. The sign was either not seen or was just ignored. There was also a lack of policies and procedures related to managing this type of equipment. Specific equipment factors also played a role in causing the incident. No one understood the vulnerability caused by the design of the telescope with the mechanics encased. There was a design flaw in the equipment, and the manufacturer had to be informed. An environmental factor that contributed to the incident was the lack of proper shelving for equipment. So by walking through the RCA process, you can improve safety defenses. You can fill up the holes in Swiss cheese and make Havarti, then cheddar. Thank you for listening. This concludes Module 4.